just give you a brief introduction. I'm just going to give you a brief introduction. First, we have Dr. Chaffin. Dr. Jeffrey Chaffin. He's the Vice President and Dental Director at Delta Dental of Iowa. Dr. Mike Plunkett is the Dental Director for Strategy and Business Development for Permanente Dental Associates. And Mary Foley, who is the Executive Director of Medicaid, Medicare CHIP Services Dental Association, or MISDA. Also today, moderating this session is a member of the AIDPH Board of Directors, Dr. Caswell Evans. Thank you very much, all of you.
Thank you. You get to a point in a session where you need somebody to maintain decorum. So I've got to maintain decorum of this group and maintain your decorum, because this is going to be a wild session, and you need somebody up here to keep it under control. So that's my particular role. We do expect to have a really informative and hopefully stimulating presentation by these individuals who not only can talk the talk, but they have walked the walk. So they will be talking from a deep experiential base. We'll start off with Dr. Plunkett. We'll then go to Mary Foley, and we will. The final speaker will then be Dr. Chaffin. Each will speak for about 7 minutes just to set up their platform, and then we will go into the Sligo question session. And I'll do my best to not only maintain decorum but handle the questions. So with that, Mike, why don't you start off?
Sure. Thank you. Mom? Yep. So thank you. First, before I say anything, I'd just like to express appreciation for being invited and to be able to serve as a liaison for my organization and for the things we represent around integration, patient-centered care, integrated systems. I don't take that lightly, that I get to talk about this and share it with you and dialogue with you. What I'd like to do in my part is talk sort of specifically about what my life as a provider, I see patients half time, and as an administrator leader in an integrated system is like day to day. So to give you a sense, to bring that to life out of the sort of the 30,000 feet into here's what it's like, here's the real business of doing that, and what I think the implications are on the system and providers. And the other is really piggyback off of what some others have said, and especially Beth set it up yesterday with the notion of what my learnings, having worked in multiple systems and now being in Kaiser Permanente, what are maybe one or two of the key elements? What are some of the mixtures in the sauce? Like garlic and tomatoes are the basis if you're from Southern Italy, right? For sauce, you start with that. Like there are some things that you start with if you want to move these ideas to an operating model, either in a state where there's integrated systems or disintegrated systems, but there's some things that you got to have. So first, just starting off with what my life as a provider like. And there's something that a couple of the Permanente Medical Group directors, or executive directors at John's role nationally, have said to me in some of my work that it takes about 3 years for a physician to become a Kaiser physician. Because they come in, they do their protocols and methods of testing, the way they think about practicing medicine. It takes them about 3 years to understand, whether they're a neurosurgeon or a primary care doc, what it truly means to be in a system that has a continuum of care and a fixed rate and salary and a sort of a goal of getting to health. And it has honestly taken me about 3 years to truly feel like in my heart, it sounds a little corny, like as a dentist in our system, what that means. And I'll tell you what that is. I get there in the morning and I pull up my patients for the day, and I do almost all oral surgery, and so it's the medical history is very important. And I see everything. I see everything. I can see when they were admitted to the ED, I can see their meds, I can see their referrals, I can see all these things, and that does something to you. It does. It makes you think about the patient differently. You're thinking about the dental care you're going to provide, but you're thinking about a whole litany of other things. Really stressful to a lot of dentists to think about that in the beginning. But once you integrate it into your practice, you can't practice without it. I would feel naked if I had to go out and daily go into a practice where I didn't know that, and I had to rely on what we know is typically erroneous, what the patient tells you about their health history. We know there's a lot of, they're not going to disclose things to you that can be vital, like anticoagulants, history of heart attack, what medicines do they take? So that's socially sensitive. I see it. And one thing that I would like to, I do a lot of wisdom teeth, and this is deeply sort of impacting to me, is I will tell you that when you have a 16-year-old patient in the room and you walk in and all you see is this, and maybe there's a parent there, maybe there's not, and they won't look at you, and you're trying to get them what kind of sedation you need, you're trying to get that information so you can care for them. If that's your interaction with them, there's something that happens. If 5 minutes before you walked in, you saw that this boy or this girl was serially sexually abused for most of their young life, don't you think that affects you? It does. And I see those things. So when I walk in and someone's behaving a certain way, I can make assumptions, but my assumptions come with a lot more knowledge about that human being. And that, if many of you have expressed both over dinner over the years, as well as in these forums, the frustrations with dentists, how recalcitrant dentists sometimes can be to change. I can tell you, if you practice in that model, from my experience and the people I work with, that changes you. That changes you. When you practice in that you become a healthcare provider, and you will leave our system with it. You'll be one of those people that leave within a year if you don't like practicing that way, because that's part of the cultural change or evolution that happens with you when you work in a truly integrated system. You can't overlook those really difficult things that human beings are going through and just look at the code that you're going to drop to get your payment. You can't. You fundamentally can't. And so I think that's some of what we deal with, is that dentists are so disintegrated from that overall provision of care and knowing what's going on in the complexity of people's lives, that it's easier sometimes to focus on their business model and what they're trying to do, because they're shielded from that, and emotionally they don't have to make that transition as a professional and a professional. So, and as an administrative leader, going from that side of my professional life to being an administrative leader, we were just talking earlier about the conversations that Delta Dental folks have with dentists in the community, and about payment and these types of things, and just giving you a snapshot into what that's like for me. If Intel, which is one of our bigger employers, they're vital, our state employees, if we're at risk, if we're having issues with cost or something they're concerned about, you know who goes and talks to them? A team. And typically it would be me, or somebody that does evidence-based care, marketing and sales, someone from patient advocacy. Like, we take a team of people to say, you are purchasing this healthcare system, and here's what everybody in that healthcare system can give you a commitment to. And that's very different than a single person saying, you don't pay me enough, Delta Dental, because you're dealing with Intel. And it's hard to translate that to that dentist that's frustrated because you've got more PPO now, that the payers are demanding that, and it's not necessarily you, the insurance company. We have to come to terms with it as provider leaders, as marketing, okay, and all that. So one more thing. And so, and the last thing I would like to say before I pass the mic is, that curve that you see where you go from fee-for-service small to systems, they don't happen overnight, like Beth said. I've come to fully believe that if you look at Cleveland Clinic, Mayo, some of our high-functioning areas of Kaiser, if you don't have transformation within the leadership of your provider leaders within that system, develop them around critical conversations, emotional intelligence, conflict resolution, working across multiple disciplinary sort of teams. If you don't have provider leadership in the healthcare system to move that, you will never get meaningful change. I don't care if you're an insurance company, if you're a public health entity, if you don't have your champions who have been identified and been invested in to actually get those skills, then you will never, we'll be in this room 10 years from now talking about why can't we move the needle. You have to have that because they know the work, they do the work. I mean, Toyota revolutionized cars because they put the frontline people right there front and center to influence how cars were made, mistakes with their manufacturing system, the same thing in healthcare. So just say, that's the one thing I could give you is if you don't invest in your people to be better leaders and better collaborators who are at the clinical level systems, you'll never, ever get meaningful change in transforming the system. I'm sorry.
There you go. Okay. All right, So hi, everybody. It's great to be here. I have a little laryngitis, so I hope that won't impact too much. We do have 5 to 7 minutes here, so I'm going to talk fast. but that's not a problem when you're from the Northeast, Boston. I'm going to talk about Medicaid transformation and what value-based purchasing means at a higher level. So you just heard Mike talk about it at a clinical level and what transformation is all about and value-based care is all about. And you can see what these transitions are looking like at a health plan level and also at a clinical level, the way he just discussed. I'm going to talk about what it means at a higher level, at a Medicaid level, and what states are really looking for as we move into Medicaid transformation and as we consider what value-based purchasing means to the states. Okay, just a little background for those of you that don't know me and have never heard of MSDA. We are a national membership organization that's made up primarily of state Medicaid dental program managers, but with all the changes that have taken place over the last decade, we have expanded our membership, of course, to include all those contract dental vendors that are actually doing the administration and the managed care and assuming more of the risk, okay, that's involved in running these programs today. Obviously, individuals and groups, researchers, dental providers and such are a big part of it. And so the comments that I bring today are really a mesh because the stakeholder community has become much more important than it was years ago, okay? So today we're going to talk about three main things. We're going to talk about infrastructure and capacity. We're going to talk about key strategies that can help support and make our dental programs at the state level more value-centric. And then what are the opportunities for stakeholders, keeping in mind that in this group alone, we have dental providers, we have researchers, academics. We also have the dental vendors, Medicaid, and public health. So a broad group, whom I would consider the stakeholders. You're all the Medicaid stakeholders. We've all seen this change in landscape over the past several years. Public health programs are being downsized. Those of you that work in state oral health programs, you know what I mean. Medicaid is expanding, and that money has to come from somewhere. A lot of it from the ACA has come from the federal government, but those dollars are shrinking, as you know, despite the fact that Medicaid is still expanding. We have new kinds of models that are emerging, administrative changes that are taking place. We've gone from our traditional fee-for-service to managed care models, where again, the managed care organizations, those vendors that are contracting with the states, are assuming more and more of the risk. And when we talk about risk, we're talking about financial risk. And the states are more and more handing that risk over to those contract vendors. But now that management model is evolving into an accountable care model. You've all heard that we are in this era of accountability. If you're going to do business with government, you're going to pay attention much more, and you're going to have to be much more accountable. So numbers and measurement are becoming more and more important. You've heard about salaried providers. We're going to talk about what that means, okay? For dentistry, we've had dentists that have worked fee-for-service forever and ever, but physicians, as you probably are somewhat aware, over 50% of physicians in this country are now paid by salary. That wave is moving into dentistry. It's a wave very bigger than every one of us in the room, and it is happening, and there's nothing we can do but learn how to surf it, okay? There are performance incentives that are going to be, that we're beginning to see. We've talked for years about evidence-based practice, but we're still stuck. We still have problems. So CMS, in their Center for Innovation, okay, is saying, okay, we respect and need evidence-based practices, but we're willing to put money into learning about some of these new innovative out-of-the-box practices. And we're going to see how these work. So we're seeing that. So yes, the states are very much in need of new ideas, value-based purchasing, financial incentives, both from the states to the vendors and from the vendors to the providers. Okay, so those incentives that we talk about are at these different levels, and every one of these levels, whether it's the state, whether it's the contract vendor, whether it's the provider, or even the beneficiary, because I know Mark already talked yesterday about it needing to be a win-win at these four levels. These four levels are critical, okay? So in this whole discussion, there's all kinds of interest about integration. And what does integration mean? From where I sit, well, let's just talk about this. From where Mike sits at the clinical level, we've talked about all kinds of dental institutions and medical institutions, educational institutions that are teaching and developing programs that help to advance providers in working with, communicating, collaborating, coordinating their services with other disciplines. At my level, at the systems level, I'm talking about the state okaying and working with managed care organizations to better integrate with those dental subcontractors that may be part of their organization. What's driving all of these changes? Of course, it's dollars and cents, you know that. Evelyn did a great job this morning, awesome job, so I'm not going to spend a lot of time on data because you presented it beautifully this morning. In 2016, those costs were at $580 billion, okay? And with enrollees, thank you, and with enrollees, 72 million. For dental, it used to be that dental costs were at 2-3% of Medicaid costs. Now they're up to 9%, okay? We have these traditional silos that we need to connect. We're still working in silos. Integration is critical. Okay, so what are states looking for? And again, I'm going to go through this very quickly. States need to increase preventive services. That's number one. They need to reduce disease incidence. They need to reduce those treatment costs. And they need to find a way to get young kids to use the system more than what they're using it. They want innovative strategies from contract vendors, advocates. Work with those contract vendors, not just with the states. Okay, to come up with ways in which we can get that younger population in, okay? We need metrics and measures that work. We've got the Dental Quality Alliance that has been developing measures, but some of those measures aren't quite as good as we originally thought that they were going to be. And very importantly, we need to reduce those PMPM. PM stands for the per member per month cost. Okay, because we need to understand that states must balance their budgets every year, and when they balance those budgets with an increased enrollment, it becomes very, very challenging. We also understand that there's more adults, that are coming into the system, and as these adults come into the system, where are we going to go with them? Okay, their disease incidence is high. Okay, and so we have to decrease this non-traumatic use of emergency room. And so while Evelyn pointed out this morning, and everyone in this room knows that adult dental is not mandatory in Medicaid programs, many states know it, recognize it, and are trying to figure out ways to deliver services. Contract vendors are actually using programs and ideas to create what we call value-add services to bring adults into the dental market and to give them dental benefits. So value-added strategies for us. We've talked a little bit about silver diamine fluoride as a means of managing disease, okay? And again, important valid measures. We need to improve beneficiary outreach. States need to make sure they need to be accountable to the federal government. We need to make sure that they too are getting as many beneficiaries as they possibly can into the system, okay? So value-added innovative strategies that can address social determinants of health. That's really important right now. Barriers to care and oral health literacy. Finishing up here, we have to implement these value-based payment models. We need to focus on quality, as you know, and not quantity. Systems integration that is actually braiding medical and dental, but also braiding the Medicaid medical managed care with Medicaid managed care dental programs. Okay, very important. And then finally, as we go into better managing of high costs in dental services, just incentives and ways to better do that. One thing we talked about this morning that is really important, and everyone in this room needs to know, that there's a lot of fraud, waste, and abuse that's taking place in dentistry. And certainly Medicaid programs are seeing their share of it. States need vendors, contract vendors, that will assure program integrity. And what that means is enhanced program integrity capacity and functionalities, early identification of abusers, okay, and assurance that once they find those abusers, that they're able to resolve those problems. So again, merging those systems, the systems are there, figuring out ways to merge them better. Oops, and there we go. Thank you.
All right, so we got here. Is it this one? Which one were you heading?
Right one.
Right one? he's probably getting that slide up. Thank you very much, David, and to the Planning Committee as well as the Board of Directors for having this session as a whole. I think it's a great topic, and so we've seen that with great turnout. And that the residents, the dental public health residents, get to hear some different topics. So as mentioned, I'm the dental director for Delta Dental of Iowa. I also run a dental public health residency for A.T. Still University, and one former resident, one current resident, and one future resident are here, so I think that's great. They'll keep me honest. My conflict of interest, I'm a Delta Dental of Iowa employee. So my charge very quickly, like speed dating, and I have a good smile, so I'm good, is that right? Okay, so is to kind of give you some thoughts about quality and some things that we've been doing about value-based from an insurer's lens. I had a bunch more things we were going to talk about, but we're going to bring that right down to kind of show you kind of boots on the ground what we've been doing. Overall, though, I think a question I wanted to pose was, do insurers care about quality? And we think, working for an insurance company, we do care about quality. It's important. We can pay in the system it is now, but we know that it has its problems and the system needs to be transformed. My CEO has been with us about 5 years, does not have a healthcare background, was in the credit card industry, and he sees how the system is not rewarding the right type of behaviors right now. We're not going to go through these. This could take a whole hour itself. These are some of the impediments that we have, and only some, in our current system to getting to what we really define as quality. But again, we'll talk about those at another time. And some of those have been mentioned throughout. So that's kind of nice for this conference where it's a build-on of many different presentations. So fee-for-service. We know fee-for-service is broken. We think it is. We just talked about Medicare in the discussion group. And so part of being Oral Health America, we were on the Capitol Hill in October, I guess, to advocate for a dental benefit in Medicare. Senator Grassley, a lot of you are aware of him. He's now the senior ranking member of the Senate. He's from Iowa. He's now also the finance chair. He told us very clearly that don't bring to Capitol Hill a Medicare dental benefit that's fee-for-service. That they've worked too long on the medical side to get rid of some of the fee-for-service components, and it would be dead on arrival. So that's important for advocates to know that. We just can't throw a dental benefit in Medicare and look like a commercial plan. It's not going to be accepted. Okay, so now what I really want to talk about is show a couple examples of some pay performance plans that we have within Iowa and then a couple of other Delta Dentals as well. And you've seen this model a couple times, and so we're working some pilots on the far end of this to try to get dentists to think about value-based payment. So first I want to talk about our Medicaid. So we are now one of 2 vendors that runs adult Medicaid, and we have a comprehensive benefit in Iowa. The first benefit, the first 3 years of it, was unique and innovative, and Iowa's kind of known for being unique and innovative. But it had a tiered system, so as members showed behavior of coming into the dentist, they got enhanced benefits every 6 months. So a pretty comprehensive benefit with no annual max. But a piece of that was the state wanted a caries risk assessment. So we implemented a caries risk assessment using Provisor, and dentists got paid to do the caries risk assessment, $8. Doesn't seem like much, because it can take a little bit of time. And the value of that risk assessment, for what we thought was, it creates conversation between the dentist and the member, and the patient. So what's the risk? What can they do to mitigate that risk down the road? We paid dentists a bonus pool that participated in doing risk assessment. So if you did 90% of your Medicaid patients, if you did a risk assessment on that year, you participated in the bonus pool. At the end of the day, they got another $50 for doing that risk assessment. So we paid. So money's a big thing here in driving behavior. We paid them this. In the first year, we paid out bonuses. So maybe, I don't know, it was 35% of the dentists who participated. We sent letters to the other dentists and said, hey, if you would have participated in this risk assessment to the threshold level, you would have gotten X dollars. And it was big dollars. Some of these offices were $30,000, $40,000, $50,000. Even after that, we could only move half of the offices to doing this risk assessment and have this patient engagement. So even if you're going to pay somebody, it doesn't mean you're going to easily change everyone. And so then our benefit did change. And now this year, we have very few offices. They still get $5 now for a risk assessment. There's no longer a bonus pool, but there's minimum number of dentists still engaged in that. So that's just a little bit about dentist behavior, and changing is challenging even if you pay them. Whoop, I'll go back. So this is the thing we're doing this year. So we have a PPO bonus pool, and I'm going to get down to the last piece of how it gets to quality. But for us, the PPO, which is a lower paying network, is very important for competition within our state, okay? So I need to get more dentists into my PPO. So there'll be a bonus pool after this year that they can participate in. They do 3 things. If they're in the PPO network at the end of the year, if they receive their payment from us via electronic funds transfer, because that is an efficiency for us and saves money for us. And they use this tool, which I'm going to show you. It's called Dentalytics. So that's our quality tool. This year, we only want them just using the tool to be an active user to engage into this platform three quarters out of 4. So this is what it is. This is Dentalytics, and this is what a provider would see, okay? It is basically a dashboard for dentists to look at the DQA measures. So we as a system, we worked this with White Collar Analytics out of Idaho, but different deltas. We didn't want to go to dentists and create a bunch of measures on our own. We wanted validated measures that the system had developed. So they basically can go in here, and it provides a dashboard for their practice. And then if they have a group of practices, they can look at a higher level, and they can see how they are doing on these measures. The percent of 6 to 9-year-olds high risk that got a sealant. We hope if they get those right procedures, the outcomes are better down the road. And they can actually drill down to patient and figure out lists of patients as well. I think that's what this says. You can drill down and this doesn't show the patient because I hid that for you. So we are trying to change conversations with dentists for them to think about validated quality measures that have long-term outcome enhancements for these individuals. We'll see how this works because we've been doing this for a couple of years. It's hard to get dentists to even look at this. It's free. Now we've added it to our bonus pool that you have to do it. Hopefully that they'll look at it. Down the road, we will probably look at, nobody's just looking at it, it'll be you making some changes on some of these measures. But first we've got to move the herd a little bit just to be aware and to look at it. Okay, and one more comment. It's funny as I roll this out to dentists, dentists tell me, I don't want you to look at my data. I'm like, well, we've always had your data. What we're doing is we are presenting it in a dashboard for you to see it. So Delta Dental of Arkansas is doing something similar, and this is an article that you'll see the slides that you can pull it up. They are actually using 5 measures in not just using Dentalytics, but they are making people move on those measures as well. So, in summary, fee-for-service has some issues, but I think insurers do care about quality, but money is an important piece to change behavior of dentists, and sometimes money is not enough either.
Wonderful presentations. Thank you so much. We had agreed that each of our panelists would speak for approximately 7 minutes to talk about their boots on the ground experience. You now have an opportunity using Sligo to pose questions to the panel, and we will try to go through those questions. While you're doing that, I will take the prerogative of the moderator and start off with a question that I think each of you touched upon. What more needs to be done to educate current dentists and future dentists regarding these changes in the dental services platform so that they're better prepared and perhaps less suspicious and more amenable to participating? And when they do participate, they participate with a stronger knowledge base as to what they're getting into.
So since I have a mic, I'll start. I'll mention one thing. I think it starts at the dental school education level. If dentists, if students go to school and they are taught that things are always going to be the same, and they are now with this fee-for-service reimbursement, and this is how you do things, and this is what quality is, that you did a crown, it fits well, the margins are great, whether it needed a crown in the first place or, that's another debate. If we don't change things at the education level, it kind of comes back to diagnostic coding, we're going to continue to have this problem.
Yeah, just briefly, I agree with that. I'm fortunate that I teach a direct class in healthcare systems and finance at the dental school in Portland. And then I lecture in the 3rd and 4th year in the practice management where we talk about that. And I've seen a transition, not only the way the student body looks, but also just the reality of their loans and understanding the finances of what the system they're getting into. They are very hungry just to understand, how can I actually be happy? Because I'm looking at what I'm going to have to pay like 6 months in. How can I make this work? We have to give them the tools to think soberly about the industry they're coming into and not just get burned in bad associateships and those types of things. So yeah, it starts with them having a basic framework for knowing they're coming into an industry that is it's being pushed by macroeconomics to consolidate, to change, to do different things. So if you're associated with a dental school, please go back and ask the Associate Deans for Academic Affairs, when are we going to start teaching these first, third, maybe fourth years, a little bit about the industry they're getting into so they can go into it with some opportunities and eyes wide open.
Yeah, I totally agree with both of my colleagues here. In addition, I think faculty at these schools need to be influenced. You know, we're skipping over a really important piece, and that's because they influence, just in their own little way, they influence these young students that are so impressionable. And so if these students have mentors or faculty that are saying, stay away from Medicaid, you know, I mean, this is what we've been hearing for years and years. It's really hard to change that. However, you know, if we can help faculty understand that this wave is coming and help them understand, you know, what that transition and what that paradigm shift is going to look like, then maybe they can be a piece to this solution.
Thank you. We do have some questions. Let's start with the top. You know, we have many models. We've talked about different models. Is there any growing consensus about the strength of any one model that seems to be preferable to other models, or are we really served well by having different approaches represented by different models?
So CRA, I think we're talking about Carey's risk assessment. I'm not an expert in that area, but my belief is reading some of the literature, there's not one model that's actually been shown to be, this is the preferred model. But when you look at the Carey's piece, the different models, they're all very similar. They ask the same kind of questions. They're trying to get at past dental experience and your preventive behavior, those types of things. I don't know that there's literature that are that predictive necessarily. But for us, it was important to create a conversation because a lot of Medicaid members, we see churn, meaning they come into the dentist, get a bunch of work done, don't come back for a long time. We were trying to break that cycle a little bit, and the Carey's risk assessment was a piece of that.
So I'm a little biased about this Carey's risk assessment. I think it's a really critical piece, and I think that dental providers have been doing it in their minds and with their patients for decades. Okay, we just haven't been necessarily labeling it or writing it down anywhere, but I think that the dental community at large has been doing this as they treat their patients. I think one of the problems that I see, and in the discussion, and everyone here has heard it, is, you know, we need a valid tool. Okay, so my question is, why do we need a valid tool? Why do we have to wait? And I know that's controversial, and I understand evidence, and I understand all of that, but the fact that that there are those that keep fighting for that, show me the validity in this tool. I mean, you know, we don't have that for so many other dental treatments. Why all of a sudden is it so important that we have this tool that has some kind of a rubber stamp on it? Every one of these tools that we've seen has, you know, 90% of overlap. So I think at the end of the day, we're really getting a very good sense of the patient's level of risk of caries. It's not a no-brainer here. So I don't know, I think we need to get away from this valid researched, you know, tool, you know, to move that forward.
This next question, we clearly have some momentum as your comments are documenting, but what can we do to even create more momentum and more movement, particularly among payers, but also among patients and other service providers? How do we create even more momentum for value-based systems?
Well, I'll just say very quickly, it's coming from the top down for Medicaid. So it's coming from CMS. CMS is, you know, making these requirements, if you will, to the states, and the states are going to definitely pass that on to their contract vendors, so it's coming.
You know, I'd say it's coming from the top down everywhere. I mean, so most organizations are not simply saying, I want to do this, and I'm going to go to the state and ask, you know, a large payer like Intel I was talking about, or the state public employees. I mean, you can tell them your model, but ultimately they're going to drive what they value because they're paying. So I would say if you want the only advice I could give is if you want to influence this, there's a political route, but there's also how can your institution, how can your organization influence the large purchasers in your state to think this is of value? And typically the public employees are the engine that drives dentistry and healthcare in the states, because it's the largest commercial group that are served by systems and insurance companies. So if you can get the teachers, firefighters, cops, and the benefit boards that actually oversee those benefits, if you can get them interested in value-based purchasing, every insurance company will be figuring out ways to develop a value purchasing model to take and work with their contractors.
So I think that's a really good comment, and I would go back to, Evelyn mentioned earlier that on the commercial dental insurance side, there's competition. So if an insurer goes out there and tries to add all these value-based things, they can do some incremental stuff, but really try to make an overall change, dentists may revolt and not be in their network, and it's anti-competitive. So a single insurer has to be careful. But I think I really wasn't thinking about what you said, but say Delta and Washington. Boeing and Amazon are huge customers of theirs. If Boeing and Amazon come together and say, we want this, I mean, Delta and Washington is going to do that for them. And the dentists are going to have to do it because there's so many lives covered from those two groups that can drive change. What I'm worried about on the Medicaid side is that different from Medicare on medical, because Medicare is a huge payer, they can really drive changes, and providers on the medical side really kind of have to take Medicare. The same isn't true, in my opinion, on the Medicaid dental side. So if we put too much change, and there needs to be change, I'm not saying it doesn't need it, but if we put too much change on the Medicaid dental side, dentists at some point are going to be like, oh, I'm done. It's one more thing you're making me do. And I hear that from dentists. They're willing to take less money because we're not paying them top dollar, but the more administrative requirements we put on them, even though there could be value in those, they're just like, okay, I'm done. I just can't do that anymore. And so I worry about having adequate access if we do that on the Medicaid side, if it becomes too burdensome. That's just my opinion.
So I'm going to push back a little, okay? Because what I've seen since Medicaid traditional programs have moved to managed care, and working so much with what used to be just the private vendors who now have this Medicaid market, and you folks operationalize Medicaid and administer it so well, do you find that dentists are dropping out of your Medicaid networks? You do.
So we have 1,650 dentists or so in Iowa. When we got to dental and Medicaid expansion for adults, we were paying, I call it PPO light. So we were paying PPO light. We had, I can't remember how many dentists in the network, but 900, 1,000, something like that. We now have lower reimbursement by another 25% below that because the state changes, and we are seeing providers drop out. Some of them stay in and just treat a few patients, but in my opinion, I don't say this too publicly, dentists are willing to accept those lower fees because a lot of people want to treat these vulnerable populations. But when you just shove more and more administrative things into them, you make it harder on them, there's a tipping point at some point where they're like, okay, I'm done. And we hear that from dentists.
Thank you. Let's move to this next question. There has been a lot of discussion at this meeting regarding workforce. So a couple of things. Is there a secret formula in terms of distribution of generalists and specialists? We can expand that. Do we have the correct workforce that we need? Do we need new additional elements? John Snyder mentioned denturists in the Kaiser Permanente program. We know that dental therapy is now not only practiced in Alaska and Minnesota, is legal in Maine and Vermont, now in Michigan and Arizona, and in 2 other states in pilot situations and in tribal situations. So what about the role of dental therapists in these programs, adding value to a value-based system?
Well, my perspective on that would be at a high level, and then getting into the therapist question, which is, most health economists that the ones that I respect and read, will point to the fact that healthcare generally in the United States, one of the major drivers of the expense is that so many things are close to the most expensive centers, the hospital, and all the diagnostics and things there. Things that shouldn't be, things that should be done at home, things that are done at home in Sweden. People can do dialysis in provinces of Sweden because they work with their institution back in Stockholm, and it dramatically lowers the cost. So when you think about a perspective that what we need is more dentists and more dental fixed facilities to solve an issue that we've identified, I just don't think that is consistent with health economic understanding. Okay, that's actually going to drive costs. I don't think we have a problem with the number of dentists. It's where they're distributed and the payer mixes and the practices and so on and so forth. So with regard to the mid-level provider question, I mean, people have different perspectives on that. I think anytime that you can provide a high quality of service for a provider that's appropriate for their scope in a system that has a continuum of care, you will lower the cost if you do it right. If you can put a mid-level provider in there where it works with the policy, where it works with the scope, and you have an environment that actually will integrate that provider into a system, you can. If all those things don't line up, my view is you can spend a lot of time, effort, and resources on something that probably could have been directed toward meaningful change. So.
Yeah, and I would say that obviously the more access points in a community or in a state, the better. But when you ask the question about ratio between dental provider and the population, we still don't have that number. 10 years ago when I was working in public health in Massachusetts, the question was, what is the ratio of dental providers to the population? We know that HRSA defines, public health shortage areas as 3,500 to 1 or 3,000 to 1 in dentists. 3,000 dentists, did I get that right? No, 3,000 patients, to each dentist, okay? But we don't know what that really means. We don't, that there's lots of controversy over that. And now you can't even find that number in a state. You used to be able to, survey all the states and say, how many dentists in your state participate in the Medicaid program? And of them, what's the ratio between that and Medicaid beneficiaries? You can't do that anymore. Okay, and the reason you can't do that anymore is because so many states have multiple dental vendors. I'll give you an example. In Arizona, there may be 15 different managed care organizations. And so if a dentist participates in one of those networks, he or she may also participate in 3, 4, 5, or 6 of the others. So you can maybe look across all the different dental vendors in any particular state and then look at that particular vendor's population and then do those ratio comparisons to identify, but then who's to say if any one of them are really actually sufficient?
I just have to comment that at one point before I came on to Kaiser, I used to tease the directors of the 4 or 5 plans that my clinic was contracted with that I see like 40,000 patients. Because I was 3,000 for this plan, I was 3,000 for this plan, 3,000 for this plan. It's like super dentist, You panel me with 20,000 people,
So my company's perspective on therapists would be that they're neutral. As a payer, if it's legal scope of practice in that state, then an insurer will pay for that, that type of provider. Like Colorado has independent practice hygienists. So payers within that state pay hygienists. So company wouldn't have an opinion. Now, a personal opinion, not my company's opinion, would be the therapists are part of the answer, but this is, again, my personal opinion, the therapists are treating disease, which needs to be done. We actually need a continuum. We need something even earlier to more prevention so that we don't have more of these people actually developing disease. So while I think the therapist is a valuable contribution to the whole system, we need to think about on the prevention side too.
We've got a question now regarding dental insurers and how can dental insurers be more effective in promoting interprofessional practice as a priority? How can they be more effective in linking interprofessional care into a value-based system?
Well, you're the standalone dental insurer on the panel.
Okay. So as you all know, we have insurance companies that, whether it's standalone dental plans or as a term, single line plans is kind of a newer term that folks are using. What was the question again? Shoot, I lost my train of thought. Interprofessional. Okay. So, it's our job to partner with health plans and make dentists more aware of the interrelationship. So it's an education piece. For us, it's partnership with health plans, having measures that make people aware of this as well, and sometimes, for example, paying for some of this interprofessional types of things. Like Delta Dental New Jersey is paying dentists to do A1Cs. So if we do that, there's more of an interprofessional piece. Now, as a sidebar, I have a young group of dentists, and they're not that young. They're newer in practice that come in twice a year. And we were talking about some of this. We were talking about HPV vaccinations recently. And this young dentist, really smart person from kind of rural Iowa, his perspective was that he believes that he should be involved in that, so he has a role, but in his small community where everybody may not be as open-minded, it may hurt him business-wise to actually get engaged in HPV. Maybe in a more metropolitan area, it's different, but in rural areas, he felt like he would be at a disadvantage business-wise. And he had a farmer in a few weeks before this meeting, he said, and he was taking a tooth out on a farmer. And, nothing against farmers, just an older gentleman, and he took his blood pressure. And the farmer was like, why would you ever do that? I just want my tooth out. And so we want to be more professional, but it has some limitations, I think, in some areas of the country, too.
Well, my perspective would be it's a little dramatic because I work for an organization that's dramatically different than the standalone dental insurance and medical insurance business. I would say that it's really existential for dental plans, right? If you think you're going to get integration of services downstream, and if you think you're going to get more truly interprofessional collaboration, and still have basically the controlled over pre-authorization, over fragmented benefits, over your industry being siloed, then you're not. Because at the end of the day, the reason our system works is because the health plan manages the relationship with the large group payers. They pay us a fixed PMPM, and they give us the model of care, and they can't use anybody else. That we are in a symbiosis. We rise and fall together. The health plan has to give up a lot of power to do that. They have to turn that model over to us. We don't do pre-auths. We own that care. But then if they don't do well, we don't do well. So I just say that that the standalone insurance industry, whether dental or medical, as it sets today, is going to have a hard time really fostering that sort of integration unless it itself changes. And that's a struggle because unless the payers want you to do it, you have no incentive to do it. And your board of directors probably won't keep you on very long if you start proposing change that undermines your relationships with the payers. So.
And I would say from a Medicaid perspective that it all involves contracts. So the state can create an RFP that requires the integration. And that RFP, if dental is a carve-in, meaning that the state contracts with a medical MCO, and that the medical MCO subcontracts with a different company, a dental MCO, that those contracts need to encourage and support that integration. A perfect example is a dental vendor where is hired by a medical managed care organization, and they're responsible for the dental care of that population. The problem is now you get into case management, okay? It doesn't make sense economically for a medical managed care company to have a whole department on case management that is separate and distinct from the dental one. Okay, I mean that relationship, and the state can control that because the state can require that of the medical managed care organization, and the medical managed care organization can set up that infrastructure so that there's a shared case management, and that's at the systems level, not at the at the care level.
Those insurance companies are still going to have to find a large, dedicated, strategic provider partner to move the needle, or else that RFP will be it'll be written. 2 years later, it'll be some decent data, and then they'll be revert back because you don't have the partners. I mean, the system change at the ground, the delivery of services has to transform for the dollars as they flow down, because if they flow into a system that's not necessarily working for what the intent of the RFP is, it won't be a good value purchase for the state. So you got to have those provider systems, and that's where I was saying yesterday, the consolidation across the country that's happening, whether it be the DSOs or whoever it is, those ultimately are going to be the partners that have economies of scale, they have division of labor ability, they have all kinds of integrated systems that they can deliver on meaningful change. We're just maybe in the early stages of it.
So kind of as a counterpoint to that, so single line carriers think that we're dental benefits. That's what we do. We can integrate, we can do some things, but we are afraid that when or if dental benefits go to embedded plans, some of those just don't focus on the dental. Some may do a good job, but many, dental is just a small piece of that, where we think we have a bigger emphasis of really focusing on the dental benefits of those individuals.
Jeff, while you got the microphone, the next two are for you. Does Iowa use the DQA sealant measures? Since you use validated measures, and what opportunity do you see for data dashboards to assist with this shift towards value-based care delivery?
Sure. So what's interesting about some of the DQA measures, Fred Eichmiller from Delta Dental, Wisconsin, was developed a lot of these measures. We call them oral health measures in the Delta system, and we used to get a report. I still get it. Every year I get this report for the state of Iowa, and it's not actionable. So many of the DQA measures are endorsed by the National Quality Forum, the NQF. So the sealant measures were endorsed by the NQF. Recently, so there's some DQA members here in the room, the endorsement was removed from those sealant measures. And so there's some working groups looking at those sealant measures. So are they truly validated? A lot of work was done to validate them, but they're no longer NQF endorsed. Would that be right, Mary?
Yeah, let me just add that they, measures are always evolving, right? And so they were put out there and they were tested, but not in the field. Now that they've been in the field and they've been tested in the field, their problems are emerging. So we would encourage that folks that are considering using the current sealant measures, that you kind of put that on hold because there are problems and we're not getting the results that we really want to. We're not getting what we thought we were getting by the use of those measures. But we are working on that. We're exploring that. We're trying to figure it out and involve it to create better measures.
Well, that sort of leads us into this very next question. What outcome measures are missing? What are the measures that we really need to further support and promulgate shift towards value-based care and their related outcomes?
So very quickly, ARC has a series of domains. Okay, there are various aspects of administration and in service delivery. Okay, there's about a half a dozen of them, these very specific domains. We've kind of, the DQA, and we've been a part of the DQA since its inception, we've focused in on one or two of those areas, access, but there's so many other areas that just we haven't even touched. So I would encourage you all to look up the ARC, the quality aims and those domains, because they really spell out all the different aspects of healthcare delivery and administration that really are a part of whether or not a program, okay, is truly a quality-based program. It's not just whether or not they're doing sealants. That's just like one teeny little thing.
Well, I would say having the other hat I could wear is that when Oregon created the coordinated care organizations, I was the dental director for an organization that owned or operated 5 of them. And so I was deeply involved with the state's efforts to identify something in dental that we could bring into the CCOs. And if you haven't, I really do believe sealants are a good place to start, because we looked at everything you could look at and found that was probably the best proxy in our profession for some evidence, as well as for a preventive approach. And also, I think our thought very early on was, there's no way these contractors, and we went from like 12%, you'll know these data, we went from like 12% all Medicaid contractors average sealant rates to now we're hitting like 32% for the Medicaid population. So, and you can't do that in lower cost unless you do it in a public health model. You got to get in schools, you got to do outreach, you got to use the appropriate workforce. So sealants, I think, are a good place to start, and if you haven't really nailed or dialed that in, I wouldn't start jumping to a whole lot of other things. I would get the public health model that actually fosters a lot of engagement with institutions like Head Starts, with schools, and get your sealant rates to where you think they're somewhat evidence-based. And then from there, those are the platforms that you can build on for other measures. But if you don't get that one, you're probably not going to succeed in other areas of quality. That's just my perspective.
And I want to add something a little controversial. So, because we are having this whole sealant issue.
That's my role. That's my role.
I know. All right, here we go. Wait till you hear this. So, instead of prevalence, the prevalence of dental sealants among a 6, 7, and 8-year-old population, how about the degree or the extent to which dental providers are delivering them? So, instead of looking at the population and the data the claims data that's coming in, how about looking at the providers and assessing, over the network, who's actually delivering them, what the extent is that they're delivering them, and making that comparison. Still sealants, okay, but measuring. So if you want to measure, I know it's very controversial, but I had to say it.
Okay. So I think outcomes is important. So the dental residents out there, if we're looking at sealants, which we know are an evidence-based thing, what outcome are we really looking for long-term? Yeah, but that's challenging, right? So we use a process measure. But I mean, sealants have a great evidence base. Nothing wrong with that at all. But it's a process measure of a sealant placement. Then we are making a leap that most of the carries is prevented from those sealants. But we need longer term outcomes to truly understand some of that, in my opinion. But those are really difficult and challenging.
We need the diagnostic codes, and then we could do that.
This question, I think, is particularly rich, and it's probably the one that we will end up with. Much of our discussion has been in the context of dental procedures and dentistry. And this question is asking, can we shift the narrative from less dentistry to oral health? And the value comes in the context of an oral health narrative and improved oral health, as opposed to a set of dental procedures per se.
Is that patient? That means patient. Do you think
right.
dental insurers have the ability to shift patient?
Right. I mean, the societal and system change to oral health improvements and oral health outcomes, as opposed to just better dentistry at a lower cost.
My perspective would be that the dental insurance company, because it's so influential in delivering the benefit, can be a strong partner in that. But it's going to take the payer, when that means, I mean, if your employer places a value on something and talks to the employees differently, it starts there. Most of the really good programs that we've developed over the years, they're in partnership with the employer. Educate your employees as to what the value of oral health and integration is. They come in, then when they hit the system, as they move through the system, they have a different expectation. The dental insurance company can foster that relationship, can partner with that employer base, with the state, whoever it may be, and start it. But it's really collective. I mean, behavioral change is very comprehensive, and it doesn't, for adults especially, it doesn't happen much after 16 years old. So I'd say, yeah, you can be a catalyst, but you're not going to do it on your own.
So I agree with that it can't be the insurer alone. There has to be a partnership. And much of commercial insurance is employer-based. And lots of times we as an insurer don't really have an ability to talk to, we call them members, dentists call them patients. We don't always have an ability to send emails and talk to them. We can provide things to employer groups. They may send it out, but with a lot of these self-insured groups, there is limitations of what you can do as an insurance company, so you don't always have access to those individuals. I had another good thought, but what was it? The interesting thing about patients is when you get appeals in and questions in, patients really trust their dentist, which is a good thing. But sometimes we didn't pay for a procedure. We didn't pay for a crown because, from our opinion, they didn't need it in the first place. The letters that come in, this dentist is the best dentist ever. This crown is fantastic. My tooth feels great. But so they really trust their dentist. They don't always trust us as much. And so that can be a challenge where we're actually trying to provide benefits for what needs to be done and what we would say is quality, long-term quality. So that's a challenge that puts us at odds because they do have a relationship with that provider and they trust that provider.
And I just want to make one comment that you might not even think about this, that we get a frustration with is we would love to talk to every employer group about what we're doing. Brokers don't want you talking to them. And your broker in the insurance industry owns that relationship between the large group employer and those contractors for the insurance that, and they have to invite you in. And so that's another element of the system that's almost existential is if you're really going to have meaningful change with the payers of the system, then, that firewall that the brokers hold so they can get that competitive rate every year, you got to break that down a little bit, and that's policy, so.
And finally, I would just say that if you want to change patient expectations, moving from services to health, then you've got to give them a metric. We all know our numbers. We know what our cholesterol should be. We know what our blood pressure should be. General public knows this, but we don't know what our dental it should be. And we rely and are dependent upon what the dentist tells us it is when we go for those services. So if there is a way to create some kind of a quote-unquote public metric that everybody understands means health, or not health, then we can do a better job of managing our own and then seeking expert advice.
Well, thank you. We're just about at our point of closure. I would like to provide each of you with an opportunity to leave us with one last pearl of wisdom, and we'll take them in the same order. Mike, and then Mary, and then Jeff.
I would just say keep the faith and keep driving. If you in my 15 years, I have to say thank you to Dr. McConough. He was one of my public health teacher back in dental school when I was thinking, am I going to oral surgery? And then he talked about some stuff that I found really interesting and thought, no, that's actually far more interesting to me than wisdom teeth all day and every day, building a practice. So Yeah, good to see you. I would say that, you know, some of the most interesting things I've worked in, both at Kaiser and then at statewide with the CCOs, you sort of finish and you don't feel like you've accomplished anything because it's so rigorous. It's not, sometimes it's not fun and sexy. It's like, it's hard work. Just keep doing it, because you may not think you're making meaningful change, but you are by being here, by thinking about this stuff, by investing your time and effort into it and building collaboration. So that's it. Just keep pushing on and keep it value-based and centered toward the public and a better healthcare system, and I think it'll move the needle.
Mary? Let's go, Mary.
I would say be open. Think out of the box. You know, we still see a lot of the problems that we saw 20 years ago, 40 years ago, so we need to think out of the box. Steve Jobs said, you know, don't bring focus. He didn't believe in, he's got 10 rules, and one of them was he didn't believe in focus groups. He says, don't bring people in and ask them what they need. Figure it out and show them what they need. And we've got a lot of smart people in this room. We need to bring in some very smart young people that think very differently than some of us older ones that have been here forever. And we need to put the problem in a box, dump it out on the table, and say, hey, show us how we can fix it differently.
So it is like speed dating, because you got to come up with an answer in a hurry. And so swipe this way or whatever that is.
So just lie about yourself. You know?
So I would say these type of forums, and continually people in the profession, and we have to get people outside of the dental profession engaged on change. And change is hard. And in my opinion, health policy, most changes happen incrementally. Not very often in one's life you're going to see major change like the ACA. Those are every 30 years-ish. So we have to be, keep at it, but we have to be okay with incremental change that hopefully over a longer period of time does end up in a larger change.
Mike Plunkett, Mary Foley, Jeff Chaffin, thanks you so much for your comments. Wonderful presentation, and you made my job so much easier because you behaved. Okay, thank you very much.